Good afternoon, everyone. I'm Sandra Clark, WHYY's Vice President for News and Civic Dialogue. Thank you for joining us today for this important conversation on racism as a public health crisis. We thank the Public Health Management Corporation for convening this panel, and we look forward to some real talk from our panelists and to your questions. The health pandemic that has overtaken the world has laid bare health and healthcare inequities. And the pandemic of racism brought to the forefront by George Floyd's killing has also brought with it fervent and unrelenting calls for real change and systemic reform across wide-ranging sectors well beyond healthcare. While this most certainly is a moment, big questions loom. Will we finally take on racism at its core? And is real change coming? So joining me today are Dr. Jaya Aysola, and she is founder and executive director of Penn Medicine's Center for Health Equity Advancement and assistant dean of inclusion and diversity at the Perelman School of Medicine. She's also an assistant professor of medicine and assistant professor of pediatrics, and her research centers on evaluating system, provider, and patient-level strategies to improve healthcare and health for marginalized populations. Don Holden Woods is Chief Social Services Officer and oversees PHMC subsidiaries Turning Points for Children and The Bridge, PHMC's Health Promotion Services Group. And under Don's leadership, Turning Points for Children has grown to be one of the largest social services agencies in the region. Amanda Atkinson is Managing Director of Child Development and Family Services, overseeing program operations for several early learning programs. The Child Development and Family Services programs seek to improve education, health, and the mental well-being of young children. Shelley Sylva is Senior Vice President and Head of U.S. Social Impact for TD Bank, leading Ready Commitment, the bank's corporate citizenship platform, which is a multi-year global initiative to more strategically and sustainably drive change. So I'm looking forward to a great conversation here, and we're going to start the conversation. So to our panelists, what's been laid bare by the pandemic isn't new to any of you. And so let's start off talking about racism and what is sometimes also termed as white supremacy culture. And how does it manifest in what you see and do? And why is now a crisis when we know this has existed for a long time? Jaya, why don't we start with you?
Sure. I think racism manifests in a myriad of ways in medicine. And I think it's sort of a root cause of both healthcare disparities and health disparities in medicine. It manifests, for example, as structural bias and influences the medical knowledge that we generate in part, as well as how we design our healthcare delivery systems to sort of unintentionally benefit some while marginalizing others. It also, at the micro level, manifests as unconscious bias among healthcare providers, as well as it manifests in how we recruit, retain, and advance our healthcare workforce. I think you're right, this crisis and racism is not at all new. I think what has probably changed in my mind is a growing acknowledgement of it and a growing demand for us to collectively combat it.
Can you talk a little bit about structural bias and what does that look like?
Sure. I think structural bias is sort of, or institutional bias, at least as it manifests in medicine, is just this understanding that the way our healthcare system is designed intrinsically has bias laden within it, where it's set up by design, unintentionally often, to benefit a select few and disadvantage others. Often this is because as a social system, it was historically constructed by one singular cultural perspective, and that of a white man over other perspectives. And so by design, it sort of has bias laden within it.
And would you mind giving us one example of that?
Sure. I think one ways that structural racism sort of manifests in medicine is just even the way our knowledge and medical knowledge is generated. So, for example, we continue to use race as a proxy for ancestry or biological differences when it's actually a social construct. So more simply put, race is not a biological category that produces unequal health outcomes because of innate differences between us by race, but rather it's a social category that impacts health because of unequal social experiences. And racism, be it structural at the system level or interpersonal, is that cross-cutting factor that creates those unequal social experiences. So in healthcare, the way we have used race in the design of medicine and thinking about it more as a biological category has actually disenfranchised groups just in that process. And our knowledge is sort of steeped on this misunderstanding of what race is. And we sometimes perceive, as we deliver care to individuals, the differences by race as innate or intrinsic to those individuals rather than something intrinsic to our systems as a healthcare system and also other social systems that have set the stage for unequal opportunities to access healthcare, unequal opportunities to have optimal access to a healthy life.
Thank you. Dawn, let's go to you. Can you talk about how you see racism and what you do?
Absolutely. So, I think one of the things that we've noticed is that oftentimes in the social service world, we tend to confuse or assume individual deficits instead of system deficits. And so, many times our participants are struggling to navigate systems because the systems, and this was a point that actually Jaya had raised as we were talking about and planning for this, is that the reason that our families struggle is because the system was never designed with their interest in mind. For me, the work that we do, you see it in like every category if we look at social determinants of health. So it's housing, it's health, it's education, it's early childhood education. I mean, it really sort of permeates in every area in all the work that we do. And for example, if we look at housing, so, Black kids, the asthma mortality rates are 8 times higher than white kids nationally. And we know that that can actually be tied to insufficient and unstable and low quality housing. We also, if you look at child welfare services, we also know that we have, families who are in our care because they have unstable housing. So not because they're physically abusing their child, not because there's addiction, but the neglect is so significant because they lack housing. And so I think these are all the ways that we start to sort of see our families in the system. But I think there are a number of things that we could do differently so that these individuals don't end up in our care and that we can really sort of focus on the folks that we really need to. So, I mean, Sandra, I don't know if that's helpful, but that's definitely a bit of like how we see this manifesting in social services.
Well, we'll come back to some of the more systemic things, but, what makes this a crisis? I mean, obviously, it's not new. So what do you think makes this moment a crisis?
So I think personally, I would say if we look at the external context, so when we look at sort of government and the external narratives, and I think in many cases, like intentional disregard for what's happening in the world, the lack of acknowledgement that even like COVID exists and that it is a pandemic. And so I think it feels like a crisis because if you look back at the crack epidemic and how that's like impacted families in, urban areas in Baltimore and Chicago and Philadelphia, we know that like the impact of COVID will feel this. Our families will feel this for many years to come. I mean, a year from now, if the economy, if we're able to restart the economy, if you've lost your job and you're in a low skilled position, you will not probably be able to find a new job. And many of the industries that people are currently working in or were employed in some of those things have closed and they will never return as they were. And so it will leave, pockets of people sort of disenfranchised for a number of years. And so I think that that's why it feels like a crisis, because I know that like we will still have to work on these issues a decade from now. But the pivotal point may have actually been sort of like COVID, but it definitely won't go away.
No, thank you. Amanda, you work with a lot of data. You work with a lot of children. What are you seeing and feeling? I mean, this is a moment, I think, that regardless of what field you're in, it really heightened so many things. And so what is on your mind? Amanda?
Yes. One of the benefits of defining the current situation as racism as a public health crisis in this moment is that it presents an opportunity to really name the breadth of structural racism's impact across all of the different sectors and the different facets that we refer to when we talk about public health. And within early learning specifically, as a systems administrator and a program director, operator, and implementer, we have seen disparities at the client level, so at the child level, disparities in the outcomes and the success that we see with families, but also in the workforce, and additionally in the sustainability and the success rates of businesses that are connected to structural racism, right? So an inability to access capital, an inability to benefit from proximate community assets if you happen to have a business that's in an area that has lower levels of civic investment. And we have made a very conscious set of efforts, I think, collectively within the early learning sector to do two things. One is kind of investigate and collect that data, as you kind of referenced before, to try and understand where we are achieving some successes and where we see promising practices that can be expanded and replicated. But at the same time, I think we have really made the intentional efforts to recognize the interconnections of these things, that in order to achieve those improved outcomes for children, it means that we also need to be supporting improved outcomes and reductions of disparity in our workforce across the stratification of the early learning workforce, and in the way we support and ensure sustainability of all of our early learning providers, particularly those that are serving families in the most at-risk communities and those that are most heavily impacted by structural racism.
Amanda, you talked about, we have lots and lots of data, right? It's collected everywhere. Do you feel in this moment that we are collecting the right data, or there's a different set of data we ought to be looking at?
Yeah, so I think about data collection as I think about many things, but as an iterative process. I think we start with our best set of informed assumptions about the data points that we think will reveal important and useful information. And I believe that a lot of that work, so the work and the lift associated with developing data management systems and implementing the very kind of, I will say, like broad reaching protocol trainings and management of the data, that those things are so resource heavy that I don't think that our systems have the agility that they need to introduce new data points and modify existing data points at scale so that we can be responsive to what we're seeing in the data and drill down into new paths of inquiry in the data that we have. So to some degree, I will say, yes, we are collecting useful data. There are data points that I think could be and should be pursued. And there are a number of, I think, barriers to getting us to the place where we're able to do that work and be responsive to the trends of the moment, and also responsive to the analysis of the data that we have on hand.
Great. We'll come back again to talk about some of the systemic barriers. Thank you. Shelley, you are, you're handling money, and everybody says all it takes is more money. So how are you seeing racism in the funding world? And what do you think makes this moment a crisis?
So first, it's a pleasure to be with everyone. It's nice to be on a panel with people that I truly admire, and the work they get to do is so impactful. So let me start there. And so when I think about my role, so I work within a financial services industry. I'm a Black woman executive, and I'm responsible for philanthropy for that institution. And so let's put a few facts about the financial services industry. So the Federal Reserve's most recent statistics show that Blacks experience adverse credit outcomes across all income levels, including Black adults making over $100,000 a year. Black adults making over $100,000 a year report being denied credit more than twice the rate of white adults. And the rate of Black adults who are unbanked, meaning they have no banking services at all, checking, savings, anything, is more than double the rate of adults overall. In addition, we are at the lowest rate of Black home ownership in our country's history. And so this is not new, right? This did not happen yesterday, the day before, or the day before that. And so I work within a system that was actually set up to disadvantage Blacks. I think the inflection point has been the recognition that the only way we can address racism is from inside out, and that there are things that we have to undo, things that we have to unpack, things that we have to challenge as an organization. And I think we've gotten there because societal pressure, and I really think and I agree with Dawn, COVID made the world stop, right? We were all at home. So we all saw the murder of George Floyd. He, unfortunately, was not the first Black male that had been murdered, but the number of people that actually saw that and experienced it made people want to move and say, we have to do different things. I think what I've seen banks do of late is say, we have a responsibility to address these issues. Both, the bank that I work for, TD, we had a session this week where we brought in experts like Jaya to come and talk to us about systemic racism, what that means, and how we can use our limited dollars and money to drive change in a systemic and real way. And so I think, personally, I'm proud of my industry's flip to understand we have to act. It's no longer about simply writing checks. It's about understanding the systems and what we can do to change them. And so we're here, but now it's time to move.
So I'm going to, on your point about the system was set up to disadvantage Blacks in particular, what does that look like? What does that mean?
So when you look historically, the Social Security Act initially was not for people that were domestic workers, right? And so if you were a domestic worker, you weren't entitled to get Social Security. And so we know later in life, how do you create wealth with no income? I most recently read She Came to Slay, the story of Harriet Tubman. And it talked about the service she gave to the United States government and how she had to fight to be recognized for that service financially. She went in, served as a nurse, served on the battlefields, but was not compensated. So the concept of uncompensated work has disadvantaged Blacks. And so once we take it from that point, we understand that people should be paid for service. So that's what I mean about systemic things that existed.
Mm-hmm. You have had personal experience with COVID. Do you want to talk about that for a minute, if you don't mind sharing?
And so I believe in science. I want to preface it by that statement. I believe when the medical professionals tell you you need to stay home and wear a mask, I believe them. Unfortunately, I think, my personal experience with COVID is that I had an uncle who was COVID positive, and within 3 days was on a ventilator, and then within 10 days was dead. His sister, who lived with him, died in the home because she never went because she was afraid that she had COVID. And so my mother lost a brother and a sister within 5 days of each other as a result of COVID. And so, you know, there's a saying that when America gets a cold, the Black community gets pneumonia. I think COVID has shown that the adverse impacts of the disease, both financially and medically, have been borne primarily by racialized people. And we have to agree that it's real and that there's things that we need to do to protect people that are vulnerable.
Well, sorry for your loss. And, you know, it's really sad to think of almost 200,000 people who had that experience as well. And I also know you have a young child, so you're dealing with this in terms of schooling as well.
Yeah, I mean, my coworkers, I put a sign on my door today during this session, do not enter. But the reality is we will be beyond this. We will progress, right? We won't always be living in a pandemic, but we could always be living with racism in the forms in which we're experiencing today, unless we all have courage to face and deal with those issues.
Thank you so much for sharing that. Let's go to the big giant question, which is about systemic change. So the American Public Health Association quoted Martin Luther King in its statement following the George Floyd murder. And they said the ultimate tragedy is not the oppression and cruelty by bad people, but the silence over that by good people. So do you agree with that? What systemic change are you seeking? And what are the barriers to that change? And Don, let's start with you.
So I absolutely agree with Dr. King's quote and everything actually that APHA has been posting around sort of racism and the fact that it really becomes a health equity issue, and that we really need to do something about it. You know, I think that, you know, individuals like myself, I'll call out Amanda because we're colleagues, but I also think that as individuals and organizations in this work, we have to really find our voice and not be silent. You know, oftentimes because the funding for the important work that we love doing, that we know is needed, is tied to systems, we don't always tell the truth, or we don't always push back and advocate in partnership with the families we serve because of fear of what that will mean for our funding. And so I think now is actually a time to build coalitions, A, so that we have, you know, varying opinions, but B, also to protect ourselves as we advocate, you know, with our families. But I definitely think that's one of the things that we need to be doing to promote system change. I think the other thing is really focusing on data. So, you know, at PHMC, like, we have a database, a household database for the five county region. And we have, you know, decades, you know, 30 years worth of data. And if you look at these data, you'll see that the trends generally aren't necessarily getting better. But we also, like, as a business community, we're not always really talking about this data enough, B, making sure we have investments from the stakeholder community to continue this research. But B, it's like, and then we have to do the hard work to decide to change, you know, like our health systems, be it private or public, like we probably need to revamp them. We need to have conversations about that. And we need to be able to do it in a way that really sort of acknowledges our collective vulnerabilities versus doing it in a way that I think casts blame for why things are the way that they are. I mean, I think most of the systems that we work within I mean, I know there are some folks who would say they've been intentionally constructed, and some things probably have, but I genuinely think that many things have unintentionally been constructed this way, and we generally don't question things. We just sort of continue to do the same thing day after day, looking for a different result. And when we do question things, we're only ever comfortable sort of tinkering around the edges, not really, I think, looking at root causes. And so I think if we spend more time acknowledging that nonprofit partners as well as government play a role in why things are the way they are in Philadelphia. And then I think being honest about, well, what will it take to begin to really, do something different, and how can we all use our expertise to do that?
Dawn, you mentioned in our earlier conversation that sometimes you have to fracture relationships with system partners. What did you mean by that? Well, I think there are a couple of things. I think one, sometimes there are fractured relationship between our system partners. Mm-hmm. So, when you're on the ground doing the work, it's oftentimes very hard to even get information about participants from, between the mental health system, the child welfare system, the private medical community. We've created a lot of barriers, I think, to protect our participants and our clients' data that oftentimes we use as excuses not to share information that would really help us build better human-centered care that's really holistic in nature. And so, I think that's one thing, is just acknowledging it. I mean, sometimes we go to meetings and people will still sort of argue about whether that's actually true. And I'm at a point where I'd like to stop having those conversations. We know that, the health department, private nonprofit partners, DHS, all of us, we're not all able to share data freely. And so that would be one simple thing that would help us, I think, more quickly identify both root causes and then work together as partners to figure out how to support families. But it's a risk to actually sometimes continue to really, push the envelope around some of these points, because people push back pretty fiercely around sort of what their systems are doing and how they move the needle, versus really having the honest dialogue that perhaps some things have improved, but there's still a lot of change and a lot of work to be done. Hey, Dawn, what do you think is the root of the pushback?
I can't fully say because I've never worked in government, but I will acknowledge, and one of my colleagues, we were talking about this recently, I think when you work in government, it's sometimes a tough place to be because people are constantly sort of scrutinizing and criticizing every decision you make. So rarely is there a policy change or improvement that's met with enthusiasm. So it's generally met with, maybe enthusiasm for a second. And then we normally sort of dive into what's wrong with the decision, what was missing, the resourcing wasn't adequate. We normally sort of dissect these things. So I think that's part of it. And so I think there's just sort of this natural defensiveness that some of our system partners have. So, I mean, I think that's a big part of it. Not the only thing, but I think that is a piece of it.
Yeah. I always think that all those little pushbacks kind of add up to a lot of paralysis sometimes, right? Jaya, you believe there's a true deficit of understanding of what the problems really are. Do you want to dive in on that one?
Yes. And I think we've already touched upon it a little bit and people have talked about it, but I really do think there remains a lack of understanding on, first, what we mean by racism. So we're afraid of the term. We are uncomfortable still talking about it. It's almost one of the first problems, or the only problems, that I think we're trying to solve without discussing it and naming it as a problem. And we don't think about it in terms of the different levels it manifests in. We think about racism oftentimes merely as interpersonal and overt, rather than unconscious, intrinsic, sometimes internalized to all groups, as well as structural. And it's really the structural piece of it that I think we need to focus on. And that paradigm shift in how we discuss and address the challenges of racism has to happen around looking more upstream and looking at the role racism plays, not just interpersonally or what we've historically kind of thought about when it comes to racism, but really how it plays a role in the ways all of our social systems are designed, from the healthcare system to the criminal justice system to the educational system. And understanding that, if we can critically understand that and collectively understand that, we will be able to then kind of start to have a systems opposite approach where we're looking more upstream at the structures and policies and practice that drive unequal opportunities to achieve optimal health care and medicine, but also what institutional factors within medicine are sort of allowed to persist that permit unequal care to persist despite our best intentions, as well as what are those same structural factors that set the stage outside our health system walls in these other sectors, like everyone's alluded to, that sort of sets the stage for unequal opportunities and disadvantages them. And I think that sort of, to answer the other question you asked in terms of what I wish needs to change, I think that paradigm shift has to happen in the way we discuss these challenges for us to really begin to collectively shift our focus towards strategies that tackle structures and structural racism rather than what we're doing right now, which is sort of much more downstream. We focus on how we want individuals, how to help patients or populations navigate our existing structures rather than looking inward, as Shelley discussed and Don discussed, but looking inward, like what are we going to really fundamentally change in the design of these systems that will get what's going on.
Yeah. So how do you, or how do we, kind of overcome the running away from the R word, right? And how do you really get down to talking about racism, not race, but racism? Where does that begin?
I mean, I can talk personally. It's interesting. Like I used to talk about this and give these same sort of lectures and talks for the last 4 or 5 years. And I would say, bias, race-based or otherwise, discrimination, race-based or otherwise, structural bias, race-based. I shied away from the term. And I remember talking with David Williams when he did the predominant research in this area in the late 90s and early 2000s. And he said when he put in the grant, he was even shy to put in the word discrimination. So we've come a long way. I think, I think demystifying the word, otherwise, making people understand that we're talking about racism and no one's immune, that we all are embedded in structures and systems that sort of lend us all, 75% of our US population has a pro-white, anti-Black bias. 50% of us that self-identify as minority have that same bias, that no one's immune to this. And I think that's some of the first steps towards sort of naming it and demystifying and decharging the word.
And I just would add, I think part of it is sitting with discomfort. I think we as organizations that have to deal with these issues think that it's bad to be uncomfortable. And it's not, uncomfortable doesn't mean not safe. Uncomfortable means uncomfortable. And I think, I'm really proud of my organization. When we initially were when everything was revving up and there was lots of discussions, we said, let's have a global town hall meeting to have an uncomfortable conversation. And I think we need to have more spaces, because I think, Jaya, you're absolutely right. I think people define racism as one person doing something to another person. Well, I'm good. I don't do that. So I'm fine. And it's bigger than that. But I think we also don't give people enough environments and safety to have those discussions, right? Where people can say, well, I don't understand. I think we all assume we're all coming to the conversation with the same information. And we know what happens when we do that. That's not the case. And so I think as organizations, we have we have an opportunity to help guide discussions that may be uncomfortable, but at the end of the day could be game changers for our employees, for the communities in which we operate, and for the communities in which we serve.
Is that a leadership issue? I mean, I think we definitely see that we come to it differently when, you know, many people have known racism has been around for forever, right? And others have just discovered that we're living in racism. And so is that a leadership? Are we at the table to be able to drive that? Because it doesn't just happen on its own, it seems.
I do think diverse leadership brings diverse perspectives. And I think we're at a different inflection point because there are more diverse leaders, and many of our prolific industries, you know, people are pushing the conversation because it's important, but leadership matters. Mm-hmm. And I think, you know, Jane Fraser was recently appointed CEO of Citibank. So she's the first woman to lead this major Wall Street financial institution. That's game changing for women. I think people underestimate the power of seeing yourself in leaders. And so as a Black woman, you know, when I saw the announcement, Dawn will tell you, I texted her immediately, oh my God, Jane is leading Citi. And I don't even know Jane, right? But her win, her presence, I'm calling her Jane, I don't know her. But her presence, her being in that space drives change. And I do agree, you can't just put people in spaces and think everybody's going to have the same fundamental understanding or fundamental want to drive change. But to be totally absent from spaces, the discussions aren't happening at all.
Yeah. Amanda, I wanted to come to you because you've been talking about race concerns about systems not centering children, and also race being politicized. And so can you talk a little about that? Can you expand? Amanda?
I don't think she can hear.
Amanda? We'll come back to Amanda when you can hear us again. Anybody want to take that question? Hello, Amanda?
Hi, can you hear me?
Hi. Yes, we can hear you.
Okay, great. Yeah, I had to refresh my page. Apologies.
Oh, no problem. Did you hear the question, Amanda? I can repeat it.
Yeah, could you repeat it? Thanks.
Sure. So you've talked to, you know, you work with children, and you've raised concerns about systems not centering children, and also about race being politicized. And so can you expand on that, and also talk about daycare workers in this as well?
Yeah, absolutely. So, you know, I think we have kind of an array of interventions and strategies that we deploy to try and, you know, address the structural issues that we recognize in early learning and in youth development programming. And I think that work is really important. I think that approach is very important. But I think there are instances where we establish, you know, proxy indicators that are not, in fact, kind of explicitly tied to the impacts and the circumstances and the needs of children, right? So, and in that way, we are centering children as the kind of end recipients and clients of a lot of the work. And you know, the scale and the complexity of what we're attempting to do across all the different early learning supports and services, I think, makes the use of kind of proxy indicators that allow coordination across different programs, that's really useful. But there's always that need to kind of come back to the question of how are we achieving impacts with children, and are we achieving the desired impacts with children, and not just in terms of kind of the aggregate data, whether or not, you know, again, 5% more children are in high quality environments and settings, but to do that more thorough investigation to say which 5% of children moved into high quality settings. Was it the 5% of children that we understand are most vulnerable and that most need these services? And if not, what additional supports and activities do we need to do to ensure that we're not just demonstrating progress in the aggregate, but that we're actually achieving kind of shifts around those disparities that are most compelling or that are deeply compelling in the work that we're doing? I have a particular kind of emphasis at this moment in time in encouraging dialogue and heightening awareness around what is happening within the early childhood workforce and what has happened in the response to the COVID-19 pandemic. I think much like others on the panel have said, these are not necessarily new issues. You know, the conditions in which early childhood workers are compensated and the benefits that they, the employment benefits that they receive or don't receive as a consequence of their work. I think those things have been long recognized as areas of concern, but this moment in this crisis, which to me is really about the fact that the magnitude of vulnerability and the depth of vulnerability is so pronounced. In this moment, we see that early childhood workers were, as many other essential workers were, at the forefront of exposure and at the forefront of transmission of COVID-19 in the course of delivering what we as a set of societal agencies have collectively been willing to say are essential services. And so, you know, if we have these workers that are really, by and large, marginalized by our current economic systems in so many ways, they're being undercompensated. You know, their health and wellness is not necessarily being addressed appropriately. The question becomes, you know, what are we doing to right that, to recognize that if these are essential services and these are essential workers, what kinds of changes are needed? Yeah.
Yeah, and I wonder who is speaking on behalf of that group of workers as well.
I think that's right. Yeah, I think it's an important issue of the moment.
Thank you. Shelley, I'm going to come back to you, and then we're going to take some questions from our audience. So, you know, you've been on a listening tour. You've also talked about how TD is going to people and to projects as opposed to waiting for proposals to come. Talk a little bit about that with that intention.
We have intentionally said that we want to support 3B organizations, Black-led, Black-run, Black-focused organizations. And we understand when we say that the lens on how we've done traditional philanthropy may look different. And so during the COVID outbreak in Philadelphia, they had the Black Doctors COVID Consortium that was taking testing directly to Black communities. And one of our drivers that we have through our corporate citizenship platform is access to care, access to screening for early interventions and treatments. And so for us, we didn't need them to wait to come to us and say, can you support us? We saw the information, we saw the data, we said we need to support them. And I think we've been taking a more proactive way into philanthropy, as Jaya knows. You know, we know the work that she's done at Penn. She's been an incredible partner. The things that she's doing directly impacts the communities in which we operate. And so we don't chase the shiny penny in terms of organizations to support. We support organizations on the ground that are interfacing in real time, providing real support to our communities in a real way. And then we measure our impact. And so as the leader of philanthropy for the US Bank, you know, that's been a core principle of mine. And I work with a team that believes in that as well. I don't think philanthropy is about people asking and begging for money. It's about us supporting the communities in a real meaningful way in partnership. Because they can't do it alone. We can't make the changes. We have to work together. And it's definitely not just a check writing exercise for us. We always think, how can we bring our capital, our cash, our people, but our brand to these relationships? That's how we think of everything that we do in that space.
How do you look at short-term investment versus long-term investment?
Very good question, Sandy. Yesterday, yeah, and so we know we have to treat 3B organizations similarly to how we treat other organizations. We know we can't say we're going to pay you this year and then we'll think about it for next year. And so as a model, when we are building a relationship, we want to see it from at least a minimum of a 3-year commitment on our part so that we can actually see progress. And so, you know, we recognize that 3B organizations have been disadvantaged in the philanthropic space. I was speaking to someone, a woman that runs a small nonprofit in Norristown, and she got funding from a big funder this year and she didn't even apply for it. And now her organization is the IT organization because someone put the stamp on her organization. She didn't change her work. Her mission hasn't changed. She's been doing the same thing for 7 years. And we have to put an equity lens on the work that we do. And there's lots of learnings for my team to do and for me to do to make sure that we're doing it appropriately.
Yeah, thank you. We have a question from Nikki. Are there any strategies to get over implicit bias? And that's open to the group. So, Jaya, you want to take that one?
Yeah. So I think when it comes to unconscious bias in patient care, the AAMC came out with Howard Ross, and they put forward this acronym called PAUSE, where, you know, if you think about unconscious bias, it's sort of our fast brain or heuristics acting. So, you know, we receive 40 million bits of information and we can only consciously process 10 of them. If you've ever been in a car, you end up in your destination and you can't remember exactly how you got there. Well, that's sort of what happens in our healthcare system when we have increased cognitive load. We're in the emergency room, we're triaging patients. We've shown that in the emergency room, during those times, our fast brain thinking kicks in, and then resort to those sort of, you know, baseline assumptions that we make with our patients or by population or by race. So one of the ways in which to mitigate that bias in patient care is to slow that down. So to pause and ask yourself, what assumptions am I potentially making? What's like the most reasonable interpretation of this interaction? And sort of a set of conditions that you sort of mindfully approach every patient in. You know, other sort of things that have emerged as we think about diversifying our workforce is the bias that is laden in the ways we recruit and retain individuals within medicine. So organizations, when we think about, well, interview processes, there's something called priming techniques where we allow interviewers after they've interviewed to screen themselves for the common biases that happen during an interview, from affinity bias, that candidate may smile may remind you of your grandmother's smile, or they go to the same, you know, alma mater as you, they're from the same school, or anchor bias, where we kind of attribute qualifications to an Ivy League education versus not. And so how do you sort of, after an interview process, use these 5 or 4 questions to say, prime yourself, was bias at play here? And so there are some strategies that we're pulling together, but in medicine, but I have to say this field is sort of in its infancy, and with unconscious bias training and some of the things that we're rolling out, there's still a lot of work to be done to see and prove its benefit. And so, you know, we're still looking to that, but those are some ideas that come to mind.
Thank you.
May I add a thought to that?
Sure, go ahead.
Jay, I think everything that you just shared was great. And I think the only 2 things that popped in my head really quickly was, one, I think as nonprofit organizations, we need to develop some guiding principles for our organizations and some sort of like agreed upon behaviors around sort of how we engage that I think would lend itself to ensuring bias isn't at play. I think that's the one thing that comes to mind. And then the other thing is really around making sure there's diversity around like public health researchers, folks doing actual data collection on the ground, in the clinics, I think that's a space where you want to make sure you actually have diverse candidates collecting the data. I think you want those folks in the room to think about, well, what are the questions we're not asking? How are the questions that we are asking not actually getting to sort of the root cause of the problems that we're seeing? And so I think so often, just because of like how education works, how salary ranges work, you don't generally have a ton of Black or Brown individuals sort of moving into public health research because it's not as lucrative as obviously sort of going into academia, where I think generally there's a sense that that's a better career trajectory. So I think if we could also be intentional around like creating fellowships and opportunity to really get Black and Brown candidates doing public health research, I think that's sort of another way to also, get at that question around bias and some support.
Okay, no, I just to sort of riff off of that, I think what you were saying reminds me of the need that we often talk about diversifying the workforce and we limit it to the front lines. But unless we diversify sort of the leaders that are designing the systems that we're going to partake in, and as well as the scientists that are generating the new medical knowledge or the public health knowledge of tomorrow, we're not going to solve the structural aspects of this at play. And so I just wanted to underscore what Don said.
Yeah, no, that's a really important point. And, oftentimes when we can get to diversity, maybe, right? You get to inclusion, sort of, and equity is kind of the last thing many people think about. So when you're thinking about equity, what comes to mind? And Shelley, you touched upon that in terms of financial support, but in philanthropy. But what comes to mind when you think of real equity happening? Amanda, you want to start?
Sure, absolutely. I think, and this is somewhat connected to what Dawn and Jaya were just discussing. It is for me about of our processes, and that we are, I think, by and large, we have a level of awareness and a willingness to accept that the structurally racist kind of practices that are embedded in our systems are not necessarily intentional, right? That there's unintentional bias, there's unintentional racism in our systems. And I think, in order to really implement and act on changing those systems requires intention, right? So to be intentional in developing processes that are inclusive, I think representation is an important part of that. But we're never going to actually be at a place where, representation is in itself sufficient. So in addition to having the representation, there is that work of saying, when we have representative folks in positions of power that can influence decision-making, we're also going to implement processes that allow us to self-check, to whether or not we're still kind of pursuing that goal of true inclusivity.
Thank you. We've got about 7 minutes left, and so let's go to Jaya on that, the next one. Health equity, what are you thinking, just off the top of your head?
So I think just to build upon what was already said, I think one of the key things we have to do is focus on that pulse check or keeping us in line. And one of the ways to do this is sort of measurement and data, as been stressed before. Whether we measure it or not, every time we institute a quality improvement or performance improvement intervention, we will have one of three equity outcomes if there's a baseline disparity. We can either widen that disparity, we can sustain that disparity, or we can narrow that disparity. And so being really intentional means that we look at all of our interventions by subgroup. We look at the data about how it's affecting different races and say, as we march forward and design our different interventions, what has this intervention done? Public health has actually widened the gaps in prior decades with their obesity campaigns, with their smoking cessation campaigns. So we can do better in this regard, and measurement's key.
To your comment, One question that we just received is, what would you say to someone who does not believe that race is a social construct, considering this talk is about health and therefore biology? Do you want to continue on that thought?
Yeah, I mean, first, I don't think it's about belief. I think there's substantial evidence to suggest that race is not a biological construct. There is more within group variation. So there's more variation in genetic variation between Black individuals than between Black and white individuals. We know from the Human Genome Project that we are more alike in genetic predisposition than non-alike. And we know that race is defined differently over time and by different cultures and across geography. So it's been socially constructed. And the difference that we see are in our biology are manifestations of our social experience of race and society. So race is often used as a proxy for genetic predisposition, but it's really a proxy for racism when it comes to the manifestations of disease amongst us.
Thank you. Final thoughts, Tom? Dawn, any final thoughts?
I'm sorry, I couldn't hear you. Could you say that one more time?
Okay. Any final thoughts?
I think one quick final thought is Sandra, I want to thank you for leading this conversation and each of the panelists for being willing to participate. I mean, I think in our day-to-day work, we need to do more of this. We need to, as Shelley said, have some conversations that may bring about discomfort, but realizing that all of this sort of pushes us forward. I don't think there's any change within an institution or the country that has ever come about without discomfort. And so I think we just have to be willing to have these conversations, be willing to say we don't know the answers. I mean, sometimes we can identify problems for which we don't have solutions yet. And I think just being willing to still push forward and remembering that I think it's part of our individual responsibility as citizens to really be engaged and honest in this work. So that's just, I guess, one final thought that I have.
Well, thank you. Thanks for the inspiration on that. And Shelley, you want to close this out?
Yeah, my only final thoughts are engage experts in the space of equity, right? There are people that have done their life's work to get these things right. And so I'm amazed that, if you were sick, you wouldn't go to a mechanic, you would go to a doctor, right? And so if you want to really drive systemic change within your organization, engage people that are experts in these fields and then listen to them and then enact the things that they recommend as best practices. And so I'm really proud that I get to work with 2 of the 3 of the other panelists pretty frequently. And they have enlightened my thinking as well as my organization's thinking around equity and what we can do as a financial institution to drive change.
Yeah. I think that's such an important point to close this out, Shelley, because I think looking for the experts, and I think there's oftentimes an over-reliance on those who are already there, who may not be experts. So real change, I think, will require a lot more work and a lot more education from people who know what they're doing. So I want to take a moment to thank all of our panelists. I mean, we easily could go on for another hour. We just started to just sort of scrape the surface. So hopefully we'll all convene again and I'll see you back and we can go even deeper. So thank you again for the opportunity to talk to all of you.
Thank you.
Thank you.
Thank you.
Thank you very much.